All right, so our next speaker is Professor Yingqi Zhao. Yingqi is associate professor at the Fred Hutch. Let me, oops, sorry. Yeah, so Yingqi has been working on a lot of interesting research in the field of dynamic treatment regimes, personalized medicine, and clinical trial design and EHR data. All of her research has been motivated with the goal to improve the patient outcomes. And today she's going to share with us about her research in the optimal monitoring. Okay, Yingqi, the floor is yours.
Thank you, Lu. Let me share my slides. Okay.
There we go.
Okay. Let me try if I can do full screen.
Can Control L.
Okay. Can you still see the screen?
I can see the screen, but it's not full screen yet.
It's still not full screen. Okay.
I found that you need to full screen first and then share. Otherwise, it will stop there.
Okay. I think let me try again. Screen. Okay. Is this now full screen?
Yes.
Okay. Yeah, thanks. Thanks, Lou, for the invitation to join this conference, and thanks everyone for coming. And today I'll be talking about some of the recent research on active surveillance. So particularly we'll propose to construct dynamic surveillance rules of some stabilized form. This is a joint work with my colleagues and a previous student. The scientific motivation under this problem is actually from an active surveillance project we're currently working on. So prostate cancer is the second most cancer diagnosis in men. And we do see a lot of diagnosis every year. However, there is a large portion of patients who actually have very low risk and do not need treatment. And there is a saying that people usually die with prostate cancer instead of people die from prostate cancer. So instead of offering aggressive treatment to prostate cancer patients once they have a diagnosis, an alternative approach is to do this active surveillance. Active surveillance is a strategy of close monitoring through blood test. So they look at this PSA level and then recommend whether to do to do prostate biopsy, which can examine whether the cancer grade has been upgraded, and if it's getting worse and the treatment is necessary. And so if people can constantly do prostate biopsy, there are also some cons by doing that. So ideally, like if they can just come back regularly and do prostate biopsy, then it's on track that they're under monitoring. But there are also some other cons for this approach because it's painful to do such to do biopsy, and also if the patient has very low risk to progress, then it's actually unnecessary to to do prostate biopsy at a very high frequency. So how we can recommend the schedule such that we can balance the pros and cons. So then for our goal is to maximize the benefits by doing necessary biopsies for individuals at higher risk, but also we want to minimize the harm by avoiding non-necessary biopsies for those at low risk. So if we look at this picture, at each decision point, so basically the idea is that if we are looking at a time window, and if it is likely that an event such as an upgrading of the cancer grade is likely to occur, then we should definitely do a biopsy at that time window. But if actually within the next time window, it's not that it's kind of like safe and it's not likely to have a progression, then we can actually skip the biopsy at this time point. So how can we frame that into a math framework? So here are some notations. The event time is the time to upgrade. So in our example, it's time to disease upgrade from lower grade to higher grade. That's getting more aggressive. And SJ is the visit time at the Jth visit. And TJ tilde is at that visit time, what's the residual event time. So we now define the dynamic surveillance rule. What can this rule inform? So particularly this rule depends on the covariate xj. That's what the information we have at the jth time point. And we output a binary decisions. Either we recommend biopsy during the next time window for the patient with xj, or we don't recommend biopsy for the next time window. So instead of just recommend biopsy every time for each time window, so this differentiate patients from doing biopsy or not doing biopsy and makes decision based on individual characteristics. So to develop such a rule, we need to develop some quantities to evaluate the quality of the rule. So what we do is to frame this into a weighted combination of true positive fraction and false positive fraction. And these weights will reflect the balance between the potential benefit and harm. So benefit is reflected by the true positive fraction. So that means how many cancers we can catch so for among those patients, indeed will be has a risk of upgrading. And false positive fraction reflect the potential harm, which means among those who won't be upgraded within the next time window, how many false alarms we will have. Like we actually think they will have the upgrading. So this true positive fraction and false positive fraction are combined in a weighted way. So which is reflected by the psi, the constant here. And in general, to determine this psi and this weight, we need to make sure that the total benefit should outweigh the total harm. And once we define that objective function, we can use our data try to estimate the TPF and the combination of TPF and FPF, and we can expand that form so easier for us to kind of to see what would be the optimal decisions at each stage. And this risk-adjusted cost-benefit function can be written in the form presented here, basically depending on at each time what's the probability that we will see an event within the next time window, and essentially the optimal dynamic surveillance rule for each stage will depend on this VJ, and VJ's form, as I said, will be related to the probabilities that you will or not having an event for the next time window. And for specifying the form of the decision rule, we considered several aspects. So first, we think a linear combination is helpful and can be easy to communicate with clinicians about using a score, a risk score that indicates this patient is at higher or lower risk. And also, we hope the decision rules that over time won't change. The form of the decision rule does not vary over time. So this is due to the fact that the patient will have many time points. Like they will keep doing this surveillance biopsy, and it's really hard to actually keep changing the score and to inform them this time based on one score and next time based on a different score. So that's why we're thinking a more stabilized form that the decision rule does not vary over time, and the coefficient of the decision rules are shared across different time points. So having these considerations in mind, we proposed two methods. The first one is the shared modeling method, which is a three-step approach that models outcomes from different stages using a model with shared parameters. And the second one is the optimization with surrogate function method. So this is based on the previous objective function that we write down the empirical form and propose the method by optimizing that form with a replacement of surrogate loss function. So recall that the global optimal dynamic surveillance rules has such a form that specifies what it looks like at each time point. So what we did is to use a working model, which can be a flexible model for the quantities involved in this decision rule. And IP's inverse probability of censoring weighting methods are used to account for censoring data. And then we estimate the pseudo outcome VJ, and then we obtain this OJ hat based on the working model in the first step. And then we model the probability of OJ hat equals to 1 using GEE method and account for clustering. So this clustering is considered at each time point within each individual, and this clustering, like each individual's observations are correlated. So GEs are used to account for that clustering. And we propose the model such that the coefficients are the same. This beta G are the same across different time points J. And the second method is the optimization with surrogate function. So again, we recall the form of the objective function, which depends on these quantities, and then we write down, we derive the estimator of this phi RACB function, and then we identify the stabilized version of DSR, dynamic surveillance rule, that optimizes this estimator. And there is an indicator function involved in that estimator. So we replace the indicator function in the estimator with the hinge loss function. There are also other alternatives, and we chose to use hinge loss function mainly due to our past experience with this. Typically, it provides a good performance. So here are some simulation studies. I skipped the theoretical results part that we actually also derived for both methods. The theoretical results actually provide ground support, support for inference procedure using Bootstrap that we will be and I'll be presenting in simulation studies and data analysis. So for simulation studies, we we use the RACB values of different DSRs as an evaluation metrics, and we have different methods for comparison. So the first one is the optimal DSRs. So if we know the form of the optimal DSRs, and then the PCGOM, it stands for partly conditional GOM model, and this methods essentially is using PCGOM to model the residual time at each time point. And then we have that coefficient in the model, and then we use a greedy search to identify the cutoff for that risk score. And then we have the time varying DSRs, which is the time varying analog of our proposed method. And the proposed one is a time invariant DSRs. And we consider two sample sizes, 400 and 1500. And we present the case where COSI equals to 0.75. And there are two biomarkers measured across 5 stages. And in the first scenario, the model generating mechanism actually ensures that the global optimal DSRs enjoys a stabilized linear form. So by considering this stabilized linear decision rule is actually will give us the optimal results. And for this setup, the average event rate is 0.135, so 13.5%. And in this case, when COSI equals to 0.75, it indicates that by using this objective function with COSI equals to 0.75, it corresponds to corresponds to the situation that no more than 9 patients should be evaluated to identify one high-grade cancer. So here are the results. So the oracle, since it's the truth is of a stabilized linear form, the oracle is the oracle coefficients can be presented here, and we can compare what we have for our proposed method to the PCGLM, and the results indicate that our proposed method performs pretty well in this case compared to the competitor. And the next table shows what the risk-adjusted cost-benefit value can be achieved using a proposed method. So here, the first column, the second column, the phi RCBS is the results under stabilized form, and the RCBR represents the results under time-varying form, time-varying decision form. So even if we think with the time-varying form, it's more flexible, we don't see like a huge difference in terms of the results for this for the proposal. And even like when sample size is small as 400, the proposed method actually has a better results compared to its time-varying version. So this could be that in a time-varying version, we need to estimate more parameters, and there are more variations. And with small sample sizes, the benefit, we may have a better benefit by using this time invariant decision rule. And for the second scenario, we generate the biomarkers using a linear mixed effects model, and we generate the failure time model without the first biomarker. And in this case, the average event rate is 30%, around 30%. And by setting CSI to 0.75, that corresponds to no more than 4 patients should be evaluated to identify one high-grade cancer. And again, we can look at these two tables. For the first table, for the coefficients of the estimated stabilized decision rule, since here we don't, the truth is not necessarily the optimal, it's not necessarily linear and has the fixed form. So we cannot directly compare. So there's no oracle results here. But we can still look at the achieved RCB values for the DSRs, and we can see that the proposed method again shows a superior performance. So we applied our method to the past data, prostate cancer active surveillance study, and it is a prospective active surveillance cohort study, and we have over 1,500 patients with a 4-year median follow-up. And in general, the estimated stabilized rule using both methods have great performances. And we used 850 patients with grade 1 prostate cancer at diagnosis, with at least one confirmatory biopsy after diagnosis, and enrolled in PASS. And the outcome is the time from confirmatory biopsy to reclassification, which is a higher grade than grade 1 based on subsequent biopsy. And the average event rate here is 12% around, And there were 6 intervals in the study. And the question again is whether the patient should take a biopsy in the next subsequent window. And we consider 2 cosine values. One cosine values is 0.5 that indicates no more than 14 patients should be biopsied. And cosine equals to 1 corresponds to the situation no more than 7 patients should be biopsied. So this we can communicate with clinicians and see which one, which value of cosine makes more sense. And a reasonable range of cosine values can also be considered. So we can look at the results under a series of cosine values to make decisions. Yeah, and here are the results. And the coefficients of the proposed methods are actually similar for different type of methods we're using. And the results, again, we have a robust performance for our data. Okay, so in summary, we propose 2 flexible approaches to estimate the dynamic surveillance rules that can balance benefit against cost. And the method can be, of course, generalized to a more high dimensional data. And another consideration is instead of informing these binary decisions, we can also try to develop methods to inform a more precise time to next measurement. Yeah, thank you for listening. And again, this is a joint work with my colleagues and a previous student. If you have any questions, you can also email me. Thank you.
Thank you, Yingqi. And that is a great talk and very interesting work. Any questions from the audience?
Yeah, I have one quick question. So yeah, hi, Yingqi, very great talk. So I'm wondering, your second simulation study, you generate the longitudinal biomarkers from a linear mixed effect model, and then you need to make the decision in the next, I think 5 or 6 time segments. So I'm wondering, like every time when you make the decision, you wait until those biomarkers available, or you actually predict at the very beginning, let's say today I will make the decision for the next 5 or 6 visits.
Oh, so yeah, so this will so every time we only make decisions for the next time window, and once we arrive at that window, and we will collect new information, so updated information for the biomarkers, and then we'll continue to make the upcoming decision. So not in the beginning we have all the decision made for all the time points.
Okay. Yeah, I was asking that question is because I'm not sure if these biomarkers are easily collected. So like, for example, in clinical practice, if these are relatively hard to collect, then you may not want to, collect them every half year. But I'm not sure in the prostate cancer because I have never worked on prostate cancer before.
Yeah, I think so for prostate cancer, the PSA, it's just a blood test, so it's not that hard to collect, and well, we recommend patients come back for a PSA test. I think that's not an hard part for surveillance. The hard part for active surveillance in prostate cancer is actually they ask them to do biopsy, and that's more difficult. So if just doing PSAs, then that's fine. It's just a blood test. Yeah, so we can get updated PSA values for each visit.
Okay, great, thank you. And also, by the way, so for the first scenario is like you define the underlying truth as the linear term. So I'm wondering, like the linear relationship. So I'm wondering, have you tried like if they slightly, deviate from linear, and then how the methods will perform? I know so you definitely will not estimate betas correctly, but I'm wondering for the phi parts. Have you?
Yeah, that's a great suggestion. Yeah, we haven't tried that, but yeah, thanks for that suggestion. We can see how that works. Yeah, so the first scenario is more kind of just not like so more kind of like artificial, like try to make the ground truth is linear. So just see like how it works. So I think based on that, we should also be able to maybe vary a little bit and see how it performs with the deviation from linear model. Yeah.
Great. Yeah, thank you.
Thank you.